presenting on behalf of Medicine 2 about a 64-year-old Mrs. G who had come from Palnadu with chief complaints of fever, intermittent episodes of pedal edema and lower back fever for 2 months and lower back pain and pedal edema for 1 month. So this is her treatment timeline. So for the above mentioned complaints, she with loose stools also, she had initially presented to at a different hospital on June 4th, where she was treated as AGE, but she was found to be worsening with altered sensorium. So she was taken to another hospital where she was treated with antibiotics, which are unknown. Which are still unknown to us, treated as a meningoencephalitis. She had recovered from her altered sensorium and had gotten discharged. And on June 24th, again, she had started developing lower back pain. She was evaluated for the same in the outside hospital, and an MRI spine was done, which showed osteolytic lesions in B12 vertebra and bilateral infective sacroiliitis. At that point, urine culture was also taken, which was positive for carbapenem-resistant E. coli. She was treated with a 3-day course of ceftazidime avibactam, to which she did not respond, and she had come to CMC post-treatment with ceftazidime. So past history wise, her past history is only significant for hypothyroidism. She's a known case for 5 years on 25 micrograms of levothyroxine. Other than that, she has no risk factors like uncontrolled diabetes. She's not no other comorbidities. She's not retropositive. There was no previous history of catheterizations in her previous hospital as well. On examination, she was a bit tachycardic. Her BP was 130/80, SpO2 was 92, and respiratory rate was 22 per minute. Systemic examination wise, it was normal. To summarize, she is a 46-year-old lady with complaints of 2 months of fever with a 1-month history of lower back pain and intermittent episodes of breathlessness and pedal edema. For the prolonged history of fever, we had considered a syndrome complex of pyrexia of unknown origin, and the following differentials were considered: infective endocarditis, tuberculosis, lymphoproliferative malignancies, autoimmune causes, and HIV-associated causes. So investigations on arrival were normal, apart from an elevated CRP of 146. Blood cultures were taken and showed growth of carbapenem-resistant E. coli. Urine culture had shown no growth. As you can see, the blood culture had shown carbapenem-resistant E. coli growth with resistance to cefoperazone, sulbactam, ceftazidime, meropenem, trimoxazole, minocycline, piptaz, and cefepime. Antibiotic assay was done for colistin, which was also found to be not sensitive. A PET CT was done, which showed a probable osteomyelitis of bilateral sacroiliac joint, and an MRI was follow-up MRI was done, which confirmed the same findings. Pus swab was taken from the site of sacroiliitis, and which also confirmed the presence of carbapenem-resistant E. coli. So I'd like to talk about two things: the prevalence of E. coli osteomyelitis and the presence of carbapenem-resistant organisms, and if they don't respond to ceftazidime avibactam, what are our options? So E. coli is a rare cause of osteomyelitis, and most commonly there are only few case reports which say such. They are most commonly seen in people who with uncontrolled diabetes with previous history of recurrent UTIs, but there are few cases that they have been present in patients with no predisposing risk factors. These are two such studies which have recently been published. So E. coli osteomyelitis most commonly involves sites at the vertebrae sacroiliac joint, or it can also present as a septic arthritis. Most common risk factors are diabetes and presence of malignancy or recurrent UTI. And most commonly treated if CRO, ceftazidime avibactam, if not third generation cephalosporins can also be used. As for this patient, because as she was already started on ceftazidime avibactam, and despite which she did not respond to the treatment, we had started looking for options which might show increased benefit. So we had given a trial of synergy with ceftazidime, avibactam, and azithromycin against as this patient outside reports had also showed metal of beta lactamase and oxa 48 positive, and so we had also tried a trial of synergy, despite which the patient did not and the day patient continued to spike fevers. Infectious disease opinion was sought, despite of a 3-day trial of ceftazidime, avibactam, and azithromycin. She continued to spike fevers. She was not clinically responding to the treatment. Hence, other options were looked out for, such as polymyxin. So this is a trial published in 2024, which shows compares the 30-day mortality between patients treated with Cefta-Avi and azithromycin versus those treated with polymyxin. So meta-analysis shows that there's a lesser 30-day mortality when of the A combination when compared to polymyxins while treating patients with carbapenem-resistant E. coli. However, since our patient was not improving on ceftazidime, avibactam, and azithromycin, we had resorted to polymyxin B, following which she has been continued on polymyxin B, and she's still admitted. She's seeming to recover. We'll plan for a 4-week course of antibiotic post-discharge. So coming to our learning points, E. coli osteomyelitis is rare, but it can involve the vertebral and extra-axial skeleton. It is usually associated with underlying comorbidities such as diabetes or malignancies, but can also present without any risk factors. The mechanism postulated is hematogenous spread via recurrent via septicemia, which can be due to a recurrent UTI. Treatment options for patients with carbapenem-resistant E. coli, ceftazidime, avibactam would be our first choice. If resistance is clean, we can try trial of synergy with azithromycin. Other options are polymyxin B. Thank you.
Any questions for her?
What is our experience? What does the preliminary results show of the combination citizen?
There is a growing resistance to the treatment because of its injudicious use outside. Not sure.
A few questions. One is the initial presentation, was it a urinary tract infection or was this a hospital acquired infection?
Oh, this is more along the lines of hospital acquired infections, but we're not really sure because she was treated multiple times with multiple antibiotics also.
We're looking at the CRO E. coli with a contagious spread to the osteomyelitis. Now has come with a bacteremic presentation of a CRO. You said no lines. Were there no long lines or catheter or dialysis port outside? Because she's been there for a month then.
Yeah. No long lines as such present prior to issues.
Here the synergy was negative, so we will not give that. Outside, did they check for it? Do we have any?
They had only given a trial of a 3-day course of ceftazidime.
Did they check for in vivo synergy? That we don't know. Sure. How is the patient doing?
She's still admitted. She's doing better on polymyxin.
How many days of antibiotic? Is she afebrile?
I'm not sure how many days of antibiotics, but she's responding to the treatment.
We are planning 6 weeks of polymyxin basis. Thank you. We'll go to the last presentation of today.